Hello, I am Eli Adashi, Professor of Medical Science at Brown University and host of Medscape One-on-One. Joining me today is Dr. Tom Frieden, Director of the Centers for Disease Control and Prevention. In an earlier conversation, we discussed the battles waged against tobacco, obesity, and healthcare-associated infections. Today, we will focus on the prevention of HIV, teen pregnancy, and motor vehicle-related injuries. Welcome.
Welcome. It's great to be here, and welcome to CDC again.
Just for the benefit of our viewers, perhaps a few words about what winnable battles actually are and how we should be thinking about them before we launch into specifics.
There are so many health problems. Sometimes it can be overwhelming. And yet a subset of them are things that affect many people, even everyone in some cases. Things that we know what to do, but we're not yet doing it. And if we implement proven programs, we're going to get great results. So for each of these areas, they're big health problems. We know what to do. We're not yet doing it. But if we focus more, we can make a lot of progress.
And these are priorities you defined or identified at the beginning of your tenure. Is that correct?
Yes, we really worked with staff at CDC and elsewhere to identify them. They're not the only winnable battles. There are others, but they're the ones that we're giving the most attention to. We have the most ability to make a big difference.
We'll begin with HIV/AIDS, very topical in many ways. We just crossed the 30-year mark of the epidemic earlier last month. And yesterday just happened to have been HIV testing day. How did that go? And what can you say about the obvious but ever-growing importance of testing?
HIV remains, despite the great treatment that we have, HIV remains an incurable infection. We have about 50,000 new HIV infections every year, especially among men who have sex with men, and especially in African Americans and Latinos. By scaling up testing and treatment, we can make a big difference. CDC initiatives over the past few years have resulted in 11 million people in America being tested for the first time. And yet we know that testing still isn't nearly common enough. We need to offer testing to everyone routinely. We need to intensify testing for groups such as men who have sex with men who may need to be tested several times a year. We need to continue to try to reduce risky behavior, and we need to get people who are positive onto treatment. One thing that doctors can do more than they're doing today is to find out about partners. Who are the partners of people who are positive, and to ensure that they get tested. Also to make sure that once people are tested and found positive, they promptly get into care and they stay in care, so that we can reduce viral load in the individual and in the community and reduce spread in the community by that means.
As we think about AIDS in general, we think about both prevention and treatment. What can we say about current efforts in the U.S. that focus on prevention first?
We're learning more what to do to prevent HIV. We're learning to focus on the geographic areas. We're learning to focus on the demographic groups, particularly young men who have sex with men. And we're learning to focus more on the programs that work. Things, for example, to work with HIV-positive people, to reduce their risk-taking behavior, to get people onto treatment, to extend availability of condoms and safe needles. These are all effective, and we need to scale them up. But we're faced with a huge problem, and that is a lot of risky behavior in younger men who have sex with men. And this is now driving the HIV epidemic in this country and other countries as well.
With that as a fact, perhaps a word, though, about the welfare of women in the U.S. Who are coping both with the risk of AIDS and with the actual disease. Where are we on that in the US, since globally there seems to be a rather substantial affliction of women?
There are significant populations at high risk in the U.S., particularly African American women and to a lesser extent Latinas. But unlike in other countries, in the U.S. HIV remains more a disease of men, and it continues to be the men who have sex with men who are accounting for most of the spread of HIV in this country. That's one reason why we're seeing a very interesting phenomenon. It used to be that prevention was here, treatment was here, and they were very unrelated. Mm-hmm. Increasingly, we're seeing the convergence of prevention and treatment. By getting people tested, into care, and on treatment, we're not only helping them to live longer and healthier lives, but reducing the risk that they will spread HIV to others.
Is testing today, being all important as it obviously is, an opt-in or an opt-out option for individuals?
No one should be forced to be tested for HIV, and no one should be tested without knowing that they're being tested. But CDC recommends that testing become routine, that it be screening as we screen for other common and treatable infections.
It might be also useful to say a word about our national strategy for the management and hopefully eventually control, if not eradication, of AIDS. It is our understanding that we now have the first ever national U.S. AIDS strategy. What can you tell our viewers about its genesis, its high points, and its goals, perhaps most importantly?
There's a real commitment in the government to do more to address HIV. There's a real concern that 30 years on, we have too much complacency within the government and within communities about HIV. It remains a leading preventable cause of death in this country. It remains an incurable infection, and we're seeing it increase in some population groups. So the national strategy says, let's do everything we can to reduce the spread of HIV, to ensure effective treatment of those living with HIV, and to reduce inequalities and disparities in HIV in our communities. Understanding that we now know more than we ever have about HIV, so we can be more effective in the programs that we implement. And that's part of what's behind our effort at CDC to focus more on the geographic areas, the demographic groups, and the programmatic interventions that are going to make the most difference, so we can get the most health value for the health dollars that we're using.
Recognizing that we are not likely to treat our way out of this epidemic anytime soon, and recognizing that prevention may well be imperfect, what's the best we can hope for in the next quarter century, since it is unlikely that, for some of us at least, the decisive end may not be in the course of our lifetime?
A quarter century is a long time to look into the future, but I certainly hope that we'll have a vaccine for HIV in that time period. I also hope we may have better treatments that may be easier to take, and even if we aren't able to eradicate the infection from an individual, perhaps the treatment will be easier to take, less burdensome, and at least as effective. But ultimately what we hope to see is a more effective and coordinated system so that we can bring down infections, identify the few infections that happen more promptly, get people into care, and see HIV receding from its current situation of continuing to expand in some groups.
To the extent that the numbers are known, how many Americans today may be eligible for therapy, but for one reason or another may not be accessing the treatment?
It's important to divide that question into subgroups. Mm-hmm. So we estimate that as many as 1 in 5 Americans living with HIV, that could be more than 200,000 people, don't know that they have HIV. Some significant proportion of them could benefit from treatment, protecting themselves, their partners, and their communities. That's one group. A second group are people who are tested and yet don't enter care. And as we've looked at this more carefully, we've been quite concerned by the high proportion. It may be about a third of people who test positive don't promptly enter care. That's a second big concern. And the third concern is people who may have started care and then dropped out. Maybe they got tired, maybe they had a problem with drugs, or they had a side effect and they didn't want to continue taking medications. And we don't yet have good systems in many jurisdictions to offer those people to come back into care. No one should ever be forced to take treatment for HIV, but that shouldn't allow society to be off the hook for offering that care to someone and going back and offering again if perhaps they're at a better place in their life where they can take it. One of the things that we've looked at is care in correctional institutions where you have many people diagnosed with HIV or coming through, and they may account for a significant proportion of those who are not adequately treated in society. How can we make sure that they're linked to the kind of services that we have in the community? And we certainly should make sure that anyone who wants to be treated for HIV in this country can be treated with state-of-the-art care.
It would seem, though, that on balance, it's not so much a question of supply as it is a question of reaching the individuals who are eligible for therapy who may not be accessing it for a whole host of reasons, which you have so eloquently listed.
It's very important to take a public health perspective on this. In many public health programs, we think about monitoring the outcome of every patient, not again to mandate treatment, but to hold providers accountable. If you've started 100 people on treatment and you've lost half of them, and you don't know that they're getting care somewhere else, you're not doing a good job. And we need to empower clinicians and healthcare systems to monitor and track that information for themselves so that they can improve it. If you're not monitoring it, you're not going to manage it. And identify the kind of interventions you need to help keep people on treatment. That might be mental health treatment, it might be drug treatment, it might be social services, it might be a more patient-friendly healthcare environment. Whatever it takes to get people to enter care, stay in care, is going to be very important.
Yes. So clearly there are a whole host of social and cultural factors that really enter into the equation. It's far from a simple matter of have drug, will treat.
Mm-hmm.
Perhaps we can move now to the teenage pregnancy challenge, wherein we can note some good news in the sense that the latest number available from 2009 appeared to suggest a nadir, the lowest ever incidence of teenage pregnancy in the U.S. Perhaps we can start by saying something about what made that possible. What kind of efforts converged to give us this set of positive numbers?
Well, I have a somewhat different take on it. Teen pregnancy is a terrible problem. It is one of the things that continues inequality and problems of social and economic and educational development in our society to a very great degree. In fact, if you look at everything in the healthcare sector, perhaps one thing that we can do that may be as or more important than anything else will be driving teen pregnancy rates down. And yet, our numbers are not good. If you compare us with other countries, we're 2, 5, 10 times higher than other developed countries in terms of our teen pregnancy rate. And it's not primarily because of the level of sexual activity of our kids. It's because of two things fundamentally. One, a social norm that doesn't say, you know, kids shouldn't be having kids. And second is easy access to comprehensive reproductive health care services for kids. What we can see is that in the communities around the country and around the world that have had more progress with reducing teen pregnancy, you may see some slight change in the age of onset of sexual activity or the number of partners, but what you primarily see is a big increase in contraceptive use. And I know that's controversial, but every doctor who cares for a teen should be taking a sexual history. This is standard recommendations of the American Academy of Pediatrics and others. There's nothing controversial about this. Making sure that healthcare providers provide services that are teen-friendly is extremely important. I know of jurisdictions that have gone out and surveyed providers who present themselves as being teen-friendly, and often they're not. It means being sensitive about how the teen wants to be related to, about how the teen and their parents want to be related to, about what the legality is of providing services to the teen with or without the knowledge and consent of the parents, about where to send bills or Medicaid bills or get access to family planning services. Mm-hmm. These are all important issues that doctors can do a lot about. We also have to look at different contraceptive technologies. There are a lot of misconceptions, for example, about IUDs. The latest scientific evidence does not suggest that IUDs increase pelvic inflammatory disease. And in fact, they're a great choice for many women and some girls as well, but they're not nearly widely used as they should be. Getting school-linked services. I've seen so many inner-city schools where kids are dropping out because they're pregnant, where kids are really condemning the next generation to growing up in poverty because of pregnancy. And we can do a lot to decrease this. It's going to take, though, real commitment on the part of doctors to ask teens, to advise them, to provide services, to be teen-friendly. So this is an area where, although we did see a slight decrease last year, really the numbers are so much higher than they should be. And even within the U.S., we see a huge variability between one state and another. And between the U.S., even the best states in the U.S. are far higher than other countries. So I think we can do a lot more to reduce teen pregnancy, and we must.
Points very well taken. We may have made progress, but not enough. Lots of work to do. What can we, in fact, learn from other developed countries that are so far ahead of us on this issue? If there were one or two lessons we could emulate, what would that be?
It's very interesting to look at what other countries have done. If you go back 30 or 40 years, they started out with rates of teen pregnancy. They were a little lower than the U.S.'s. But over the past 40 years, our rates have come down a little. Theirs have come down tremendously. So you see this huge divergence of rates. And fundamentally, I believe they've done two things. The first is to change the social norm, to make clear that it's not okay for kids to have kids. It's a real problem. It's not socially acceptable. Now, at the same time, we have to recognize that some teens will have children, and we need to help those children in every way possible. But that social norm is very important. And the second is ready access to contraception, that it's seen much more normally in many of the countries that have decreased their rates substantially in Europe, and Canada, and elsewhere, that this is a part of life, and whereas here there may be some skittishness about talking about contraception, mm-hmm. I think there it's just the norm, and it would be odd not to talk about it. So those two things are really both changes in the social norm in society and in doctors' offices.
You made reference to significant variability among states within the Union. Are there other differentials, if you will, that relate to racial and ethnic background, or perhaps high-risk groups that tend to have higher rates of teenage pregnancy than others?
Unfortunately, it's the groups that frequently have too large a burden of health problems of a whole wide range, including African American, Latino, poor teens are more likely to have kids. There's also a geographic effect. Some states have much higher rates than others, and some states have made a lot of progress. California took concerted action to reduce teen pregnancy, and in all of their racial and ethnic groups, they've seen a substantial reduction. So progress is possible here.
Perhaps we can move on now to motor vehicle-related injuries, which I suspect most of our viewers, that includes myself, may not recognize that this particular challenge is a top 10 challenge. and that among the various causes of death that Americans experience, this is a significant one. You obviously identified this as a worthwhile preventable target. Where are we today on this score, and are we moving in the right direction?
We've made a lot of progress reducing motor vehicle crashes and fatalities, but we still have a lot further to go. Once again, if you compare the U.S. with the world leaders, we've got 2 or 3 times higher rates of fatal motor vehicle fatalities. And motor vehicle crashes remain the leading cause of death for 5 to 34-year-olds in this country. That's a striking statistic if you think about it. 5 to 34, these are crucial years. All of us would recognize the terrible tragedy of anyone in that age group dying, and the number 1 cause of death is motor vehicle crashes. We know to a great extent how to reduce motor vehicle crashes, and we know that the progress that we've been making is related to the efforts that have been undertaken in the past. Safer roads, safer cars, less drunk driving, less alcohol impaired driving, graduated driver's licenses so that kids who are not yet mature as drivers are less likely to get into trouble driving, motor vehicle restraints or car restraints, safe child seats, as well as better enforcement of traffic laws and other measures that can substantially reduce motor vehicle crashes and fatalities. Primary seatbelt laws, very important. If you look at what's happened over the past decade, 2 decades, around the country, states have enacted stronger laws to ensure people wear seatbelts, don't drive when they're alcohol impaired, use booster seats for kids, have graduated driver's licenses for new drivers, and those interventions are making a big difference. But if we continue to make that kind of progress, we can save many more lives, save a lot of money, and have our roads safer places to drive, walk, and bicycle.
You made fine mention of several risk groups, beginning with teenage drivers, obviously young children, the driver under the influence, and others. More recently, there has been a great deal of emphasis on the distracted driver, the one who might be texting or speaking on the phone while driving. Where do you see that? Where do you stand on that, now that we've had that debate for probably about a year or 2?
I think there's a broad and growing consensus that distracted driving is a serious problem and that it's appropriate for governmental action to reduce it. You don't want your kid to be run over by a car on the way to school because the driver was texting. This is a big issue for our kids who may be very tied to their phones and other mobile devices. It's one of 2 big trends that we need to address in motor vehicle safety. One is distracted driving, particularly among the young, and the second is impaired driving among the elderly.
Yes.
As our society ages, more and more people need desperately to drive to maintain their independence, but may not be able to drive safely. And we as a society need to think of and understand, analyze, study better ways to address both of those important problems.
In the time remaining, moving to a very different sphere, most of our viewers, like the rest of the nation, have followed with great interest the events in Europe as they related to a particularly virulent strain of E. coli that created a hemolytic uremic syndrome in a substantial number of European citizens, mostly in Germany, to some degree in France. Have we been involved with that effort, or have we been mostly in an observational capacity? And what, if anything, can be learned from that episode in general and about the possibility that something of this nature could reach our shores?
CDC has been consulting informally with the authorities in Europe on this from the early days of the outbreak, both in terms of the epidemiology and the laboratory aspects and some of the tracing of food. I think the lesson is a broader one. The lesson is about food safety and the importance of maintaining our vigilance on food safety, of being prepared. We are right now in a terrible time. States throughout the U.S. are laying off public health staff. They're closing public health laboratories. They're less and less able to detect and respond to health threats, such as foodborne illness. And we have to preserve the core public health functions of this country, or we will suffer from avoidable illness, economic loss, and disruption in the producer, the whole chain of production. There's a more specific message about sprouts, which is a challenge. Sprouts can be contaminated within the seed, and even if you grow them in sterile conditions, you can have a huge amount of microbiological contamination. So this is a real concern for sprouts, and for 15 years the Food and Drug Administration has recommended that the very young, the very old, pregnant women, and immunosuppressed people not consume uncooked sprouts. This is something that I think not many people realize.
No.
But unfortunately, though it's a vegetable and we promote consumption of vegetables, there are real problems with making it in a sterile environment and avoiding contamination. But that's a very specific issue. The more broad issue is the importance of investing in our public health infrastructure, our capacity to identify problems quickly and respond quickly. I'll give you an interesting example.
Please.
On E. coli 0157H7, hemolytic uremic syndrome. We had earlier this year, just about a month before the German outbreak, we had a cluster of cases in 3 different states. Now, it was a small cluster, only a handful of cases, ultimately only 8 cases. But because we do DNA fingerprinting on all of the 0157H7, we were able to promptly identify that these cases, which were among other sporadic cases, were linked, do an epidemiologic study, identify one particular nut as the source, and get that nut removed from the shelves to prevent an outbreak. That's the kind of success that public health can have, that we need to continue to invest in so we can continue to have and continue to build on the progress that we've made in food safety.
I take it that obliquely you are making reference to some of the pressures that are currently being brought to bear on all budgets because of the both national and state pressures to cut costs and increase revenues. And I think the point you're making is that breaches in our public health defense lines can lead to significant adverse consequences.
If we don't maintain our defenses, it will cost us lives and money, and it will have an economic impact on our country as we lose confidence in some food sources. The state and local governments around the U.S. are facing fiscal crises of a severity that they have not seen in years, decades, or even a generation or two. And at the federal level, we're also seeing problems. We all understand the need to get our fiscal house in order. But what we're saying in public health is, let's not implement cuts that cost people's lives.
An ounce of prevention is still applicable.
Absolutely.
If I may, on a personal note, say that you have dedicated your professional life to the betterment of health in general and perhaps public health in particular. At what point did you realize that this is what you actually wanted to do with your professional life, and why?
Well, I love clinical care. I love taking care of patients. My father was a cardiologist, and I got a chance to observe him caring for patients and spend a month with him as a preceptorship in medical school. But I wanted to really have a broader impact on health, and I think the wonderful thing about public health is that we have the ability not just to diagnose and provide treatment and advice to individuals, but detect and provide information to communities to help communities take control of their health and reduce avoidable illnesses and deaths.
Well, it's good to have you at the helm.
Thank you very much.
On this note, sincere thanks to Dr. Frieden and to you, our viewers, for joining Medscape One-on-One. Until next time, I am Adashi.